Good morning, class. Today's topic is spine exercises and its interventions. So, the basic concept of spinal management with exercise, kinesthetic awareness, mobility and flexibility, muscle performing, stabilization, muscle endurance, and strength training. Next, basic concept of spinal exercise management with exercises. Fundamental interventions are exercise or skills that all patients with spinal impairments should learn regardless of their functional level at the time of examination and initial treatment. It includes basic kinesthetic training, basic spinal stabilization training, and functional training of basic body mechanics. Kinesthetic training, it includes awareness and control of safe spinal motion, head nodding, and pelvic tilts, awareness of neural spinal position while supine, prone, sitting, and standing, awareness of effect of activities of daily living, extremity motion on the spine, stabilization training, core muscle activation and sustained contractions includes cervical region, control axial extension and craniocervical flexion and lower cervical upper thoracic extensions. Lumbar region, drawing in maneuver and multi-fights muscle activation techniques. Global muscle control of spinal posture with extremity loading. It includes passive support of spinal posture if needed, progress to active control, coordinate core muscle activation with maintenance of a stable spine, in neural spinal position with the arm and leg motion. Fundamental training include basic body mechanics with stable spine, log roll spine to prone, prone to spine, prone to supine, transition from supine to sideline to sitting and return, transition from sit to stand and return, and walking. Fundamental interventions are patient education. It includes component of every goal and intervention. It encompasses three ideas. Patient is a participant in identifying the desired outcome. Patient needed to educate about its condition, stages, and how to manage and be engaged at activities at each stage of recovery. Patient needs instruction in prevention. General exercise guidelines are stages of tissue healing, stages of rehabilitation, and functional expectations. Kinesthetic awareness are mobility, flexibility, muscle performance, cardiopulmonary endurance, functional activities. Spinal rehabilitation, some stages of healing, acute, subacute, and chronic. Stages of rehabilitation, early training protection, basic training control motion, intermediate to advanced training, return to function phase, functional expectations, control symptoms, activity of daily living if possible, and limited work, return to work, recreation, and sports. Kinesthetic awareness, it includes goal to develop proprioception of spinal positioning, safe movement, and postural control. Element of kinesthetic training, fundamental training are position of symptoms relief, position of bias, resting position, the neutral spine position is mid-range, cervical spine, patient position, begin supine, progress to sitting, and other functional postures as tolerated. Passively move the head and neck with gentle nodding motion of the head into flexion and extension, side bending and rotation to find the most comfortable position of the patient. If necessary, prop the head and neck with pillows. Describe the mechanics of what you are doing to the patient. Have the patients identify the change in symptoms as movement occur in and out of the position of bias. Have the patient practice moving into and out of the position to develop control. If patient cannot maintain this position while sitting and standing, wearing a cervical collar may be appropriate during the accurate stage. Lumbar spine, patient position, begin with the supine or hook line, then sitting, standing and quadruped. Teach the patient to move his or her pelvis into an interior and posterior pelvic tilt through the range that is comfortable. Once the patient has moved the pelvis and spine through a safe range of motion, instruct him or her to find the position of greatest symptoms relief. If active movement and control is not possible, teach the patient the passive positioning. Passive positioning of lumbar spine. Supine, hook line, flex the lumbar spine, legs extended, extend the spine, a pillow under the bed, flex the neck, a small roll under the neck, stabilize a mild lordosis with the head neutral. For prone, use a pillow under the abdomen, flex the lumbar spine, no pillow extend to the spine to maintain the cervical spine in neutral alignment without rotation. A split table or a small towel roll placed under the forehead provide spaces for the nose so that the patient doesn't turn the head. Passive positioning of lumbar spine sitting usually causes spinal flexion, especially if the hips and knees are flexed. For flexion, the feet are propped up on a small foot stool to emphasize extension. A lumbar pillow or a towel roll is placed in the lower back region. To unweigh the spine, the arms are placed on an armrest or a recycling chair is used. For standing, usually cause spinal extension. To emphasize flexion, one foot is placed on the small stool. Lumbar spine, patient position begin with the supine or hook line, then sitting, standing or quadruped. Teach the patient to move his or her pelvis into an anterior and posterior pelvic tilt through the range that is comfortable. Once the patient has moved the pelvis and the spine through a safe range of motion, instruct him or her to find the position of greatest symptoms relief. If active movement and control is not possible, teach the patient the passive positioning. While supine passively position the pelvis in posterior, patient by placing the lower extremity in the hook line position or anterior tilt by gently pulling on the extended legs or placing a small under the lumbar spine, sitting and standing. Effect of movement on the spine. Movements of extremity away from the trunk cause spinal extension. Movements of extremity towards the trunk cause spinal flexion. Have the patient find the neutral or functional spine position Then move the arms and the legs to feel the effect on the spine. Control the spinal position is emphasized. If the patient cannot maintain control or the symptoms are made worse, he or she require passive support or passive positioning when initiating stabilizing exercise. Integration of kinesthetic training with stabilization exercises and fundamental body mechanics. Once awareness of safe positions and movement is learned, teach the patient the fundamental stabilization techniques for developing the neuromuscular control of the position and teach the fundamental body mechanics of rolling, moving, supine to sit, sit to stand, and ambulation. Progression to active and habitual control of posture. Integrate the awareness of posture and control of the spinal segment into all stabilization exercises, aerobic conditioning, and fundamental training activities. Observe the patient as greater challenges to activities are performed. If necessary, provide reminders to find the neutral spine position and to initiate contraction of the stabilizing muscle prior to activity. Mobility and flexibility. Goal to increase range of motion of specific structure that affect alignment and mobility in the neck and trunk. If there are posture that relieve symptoms but are difficult to assume because of tissue restrictions or fluid stresses, stretching or repetitive movement into restricted range may be appropriate. Stretch traction force on acute nerve irritation from bony spurs or lipping in an arthritic spine may widen foramina and relieve and the symptoms. Decreased mobility in structure in the upper extremity and lower extremity that restrict normal postural alignment may be stretched or mobilized if the technique do not stress the area of inflammation. Cervical and upper thoracic region stretching techniques to increase thoracic extension. Self-stretchings are patient position, hook lying with the hand behind the head and elbow resting on the mat. Procedure to increase the stretch, place a pad or rolled towel lengthwise under the thoracic spine between the scapula. Segmental breathing can also be used by the patient to start with elbow together in front of face, then inhaling as the elbow are brought down to the mat, holding, then exhaling as the elbow are brought together again. To increase thoracic extension, second method is patient position hook line with both arms elevated overhead. Procedure, the patient attempt to keep the back flat on the mat while inhaling and expanding the anterior thorax. Third method is patient position supine with foam roll placed longitudinally down the length of the spine. Procedure, if the patient cannot balance on the roll or experience tenderness along the spinous process from the pressure tape, two forms roll together. The patient elevate both arms overhead into a touchdown position and allow gravity to apply the stretch force. The patient then abduct and laterally rotate both shoulders so the hands are facing the ceiling. and breathing exercise can be added to mobilize the ribs to increase thoracic extension. Patient position, hook lying with both arms elevate overhead. Procedure, patient attempts to keep the back flat on the mat while inhaling and expanding the anterior thorax. Method 4. Patient position sitting on a arm on a firm, straight back chair with the hand behind the head or held abducted and externally rotated 90-degree. Procedure. The patient then bring out the elbow out to the side as the scapula are abducted and the thoracic spine is extended. To combine the breathing, have the patient inhale as he or she takes the elbow out of the face and exhale as the elbows are brought in the front of the face. To increase axial extension, cervical retraction, scalene muscle stretch, manual stretching, patient position sitting, procedure, have the patient do axial extension, chin tucks, straightens neck, and then side bends the neck opposite and rotate it toward the tight muscle. Physiotherapy stand behind the patient and stabilize upper ribs with one hand over the top of the rib cage on the side of the tightness and stabilize the head with the other hand around the side of the patient's head and face holding the head against your trunk. The patient inhale and exhale. Stabilize the ribs with a downward pressure as the patient inhales again. Repeat this procedure again. Gentle, hold, relax, stretching maneuver. Self-stretching of scalene muscle. Patient position standing next to a table or holding onto its underside. Procedure, have the patient do axial extension, chin tuck, tendon, neck, and then side bends the neck opposite and rotate it toward the right tight muscle. Have the patient stabilize the head by placing the opposite hand on the back of occipital region. To stretch, he leans away from the table, inhale or exhale, and hold the stretch position. To increase upper cervical flexion, manual stretching. Patient position sitting. Identify the spinous process of the C2. Stabilize it with your thumb or with MCP joint. Then thumb and the index finger around the transverse procedure. Have the patient slowly nod, doing just a tipping motion or the head on the other upper spine. Guide the movement by placing the other hand across the patient's head. To increase upper cervical flexion, second method, patient position supine. Physiotherapist position is sit on a stool at the head of the treatment table with your forearm resting on the table. Procedure. One hand stabilize the C2. Note the patient's head with the hand under the occiput to take the slack of suboccipital muscle. Then ask the patient to roll the eyes upward. After holding for 6 seconds, ask the patient to roll the eyes downward. As the occipital muscle relax, take up the slack by passively nodding the head through any range. Only motion between occiput and C2 should occur. To increase upper cervical flexion, self-stretching, patient position, supine or sitting procedure, instruct the patient to nod the head, bringing the chin toward the larynx until a stretch is felt in the suboccipital area, putting light pressure under the occipital region with the palm of your hand while tipping the patient's head forward reinforces the motion. Traction as a stretching technique. Manual traction, angle of pull, head position, and placement of force can be controlled by the physiotherapist. Patient position, supine on a treatment table. Therapist position, standing at the head of the treatment table, supporting the weight of the patient's head in the hand. Hand placement depends on comfort. Suggestions include placing finger of both the hands under the occiput, placing one hand over the forehead and the other hand under the occiput, placing the index finger around the spinous process above the vertebral level to be moved. This hand placement provides a specific traction only to the vertebral segment below the level at which the fingers are placed. A belt around the therapist's hip can be used to reinforce the finger and increase the ease of applying the traction force. Traction as a stretching technique procedure. Vary the patient's head position in flexion, extension, side bending, and side bending with rotation until the tissue to be stretched is taut. Then apply a traction force by assuming a stable stance by leaning backward in controlled manner. If a belt is used, the force is transmitted through the belt. The force is usually applied intermittently with smooth and gradual building and release of traction force. The intensity and duration are usually limited by physiotherapist's strength and endurance. Mid and lower thoracic and lumbar region stretching technique to increase lumbar flexion, assisted stretching, patient position cross sitting procedure. Have the patient place the hand behind the neck, adduct the scapulae, and extend the thoracic spine. This lock the thoracic vertebrae. Have the patient then lean the thorax forward onto the pelvis, flexing only at the lumbar spine. Stabilize the pelvis by pulling back on the anterior superior iliac spine. Self-stretching, patient position and procedure, hook line. Have the patient first bring one knee and then the other toward the chest. Clasp the hand around the thighs, pull them to the chest, elevating the sacrum of the mat. Patient should not grasp around the tibia. It places stress on the knee joint as the stretch force is applied. Patient position and procedure are quadruped on the hands and knees. Have the patient perform a posterior pelvic tilt without rounding the thorax. Concentrate on the flexing the lumbar spine, not the thoracic spine. Hold the position, then relax and then repeat. Self-stretching. This time bring hips back to the feet. Hold, then return to the hand and knees position. This also stretches the gluteus maximus, quadriceps femoris and shoulder extensors muscle. To increase lumbar extension, self-stretch. Patient position and procedure include prone with the hand placed under the shoulder. Have the patient extend the elbow and lift the thorax up off the mat, but keep the pelvis down on the mat. This is a prone press up. To increase stretch force, the pelvis can be strapped to the treatment table. This exercise also stretches the hip flexor muscle and soft tissue anterior to the hip. Patient precision and procedure. Standing with the hand placed in the low back area, instruct the patient to lean backward. Patient precision and procedure, quadruped, hand and knees. Instruct the patient to allow the spine to sag, creating lumbar extension. This alternated with posterior pelvic tilt can also be used to teach the patient how to control pelvic motion. To increase lateral flexibility of the spine. Patient position and procedure. Prone. Stabilize the patient at the iliac crest manually with to increase lateral flexibility of the spine. Patient position and procedure. Prone. Stabilize the patient at the iliac crest, manual or with a belt on the side of the concavity. Have the patient reach toward the knee with the arm on the convex side of the curve while stretching the opposite arm up the overhead. Instruct the patient to breathe in and expand the rib cage on the side being stretched. Patient position and procedure. Prone. Have the patient stabilize the upper trunk thoracic curve by holding onto the edge of the mat table with the arm. Lift the hip and the legs and laterally bend the trunk away from the concavity. Patient position and procedure. Heel sitting. Have the patient lean forward so the abdomen rests on the anterior thighs. The arms are stretched overhead bilaterally and the hands are flat on the floor. Then have the patient laterally bend the trunk away from the concavity by walking the hand to the convex side of the curve. Hold the position for sustained stretch. Patient position and procedure. Side lying on the convex side of the curve. Place a rolled towel at the apex of the curve. Have the patient reach overhead with the top arm. Stabilize the patient at the iliac crest. Do not allow the patient to roll forward or backward during the stretch. Hold the position for a sustained period of time. To increase lateral flexibility of the spine, patient position and procedure are side lying over the edge of the mat table with a rolled towel at the apex of the curve and the top arm stretched overhead. Stabilize the iliac crest. Hold this head down position as long as possible. Traction as a stretching technique. Manual traction for lumbar spine. At least one half of the body weight of the patient must be moved and the coefficient of friction of the part to be moved. Also, move must be overcome to cause vertebral distraction and stretching. Patient position supine or prone. Stabilize the thorax with a harness that is secure to the head end of the table or have an assistant stabilize the patient by standing at the head of the table and holding the patient's arm. Position the patient so there is maximal stretch on the hypomobile tissue. To stretch into extension, extend the hip. To stretch into flexion, flex the hip. To stretch into side bending, move the lower extremity to one side. Therapist position and procedure are: position yourself so the effective body mechanics and body weight can be used. If the lower extremities are extended to emphasize spinal extension, exert the pull at the ankles. If lower extremities are flexed to emphasize spinal flexion, drap the leg over your shoulders and exert the stretch force with your arms wrapped across the patient's thigh. As an alternative, place a pelvic belt with straps around the patient's manual pull on the strap. Positional traction or lumbar spine. Patient position sideline with the side to be stretched uppermost. A roll blanket is placed under the spine at the level where the traction force is desired. This causes side bending away from the side to be treated and therefore upward gliding of the facet. Therapist position standing at the side of the treatment table facing the patient. Determine the segment that is to receive most of the traction force and palpate the spinous processes at the level and the level above. Positional traction lumbar spine. Second procedure, the patient relax in the side bend position. Rotation is added to isolate a distraction. Force to desired level. Rotate the upper trunk by gentle pulling on the arm on which the patient is lying while simultaneously palpating the spinous process with your other hand to determine when rotation has arrived at the level just above the joint to be distracted. Then flex the patient's uppermost thigh, again palpating the spinous process until flexion of the lower portion of the spinous process spine occurs at the desired level. The segment at which these two opposing forces meet now has maximum positional distraction force. Muscle performance, stabilization, muscle endurance, and strengthening training. There are some goals to activate and develop neuromuscular control of core and global spinal stabilizing muscle to support the spine against external loading, develop endurance, strength in the muscle of axial skeleton for functional activities, develop control of balance in stable and unstable situations. Thank you.